Hello, this is Sheila Sheth, and today I'm going to talk about ultrasound contrast principles and applications. So we talk about what are these microbubbles that we use for ultrasound contrast, the principles of imaging, some practical consideration, and then we'll spend some time looking at specific indications and examples. So ultrasound contrast agents are microbubbles, and the ones that are approved by the FDA in the United States is Lumison, which is made by Bracco. And these are consist of inert low solubility gas, which is a sulfur hexafluoride, which is surrounded by a phospholipid shell. Typically, the diameter is 2 to 8 microns, so the size of red blood cells, and so they pass easily through lung capillaries. And when they're injected in circulation, they stay within the capillary bed. So it is important to understand that they remain intravascular. So unlike a CT or MR contrast agents, there is no interstitial or equilibrium phase, and they remain intravascular for several minutes. They're finally excreted by the lungs or exhaled by the lungs, and they are not nephrotoxic. So the way it works is that these microbubbles are echo enhancer, which, because of the change in acoustic impedance between bubbles and blood. And when they're insonated, they resonate. And they resonate at the fundamental frequency, and then multiple harmonics of the fundamental frequency with decrease in intensity. So they're basically non-linear reflectors. By contrast, tissue are linear reflectors at the fundamental frequency. So the way we image these microbubbles is use some sort of cancellation technique. For example, the pulse inversion recovery technique is one cancellation technique where an ultrasound pulse is transmitted, and within a few seconds, an inverted pulse is also transmitted. So when and what we looked at the sum of those two echoes. So in the tissue, because they're linear reflectors, the sum of echo is 0, where because the bubbles are non-linear reflectors, they have a positive sum of echoes. And so essentially it is a subsection technique, as I said. So to be able to do contrast ultrasound, you need to have the contrast software on your machine. And what this does is use a low mechanical index to minimize bubble destruction, and a tissue cancellation technique, either pulse inversion, as I talked about, or power modulation. So when you start, you have this grayscale, there's always a dual screen with a grayscale image, and because of the low mechanical index, the grayscale image is a little bit degraded. And before the bubbles appear, basically the tissues is completely dark because the two pulses cancel each other. And then once you inject the bubble and you look, and we do a video clip, then you see that the contrast is basically appears as bright, just because here this is a cholangiocarcinoma, which is enhancing in the early arterial phase more than the surrounding liver parenchyma. So what kind of applications is that useful for? Well, it's very useful in characterization of mass in patient who has renal insufficiency, or a patient who has iodinated contrast allergy who cannot get an MR. It's also useful for characterization of lesions that are found incidentally on ultrasound, proven normal variants, such as, for example, the colon and Bartin. It's extremely useful for characterization of cystic lesions, particularly in the kidney. It's extremely helpful to evaluate complex renal cystic lesions, whether they are solid or just complex cyst. We use it a lot also on preparation for ultrasound-guided either biopsy or ablation procedures. And finally, you can also use them to look for organ perfusion, and I'll show you examples of all of these. So the advantage, again, is that they're not nephrotoxic, that they have a different allergy profile than iodinated agents, and their allergy profile is actually excellent, about comparable to gadolinium. A very important advantage is that because you record real time from the start of contrast administration to minutes within the procedure, you can use continuous monitoring and visualization of small blood vessels from the start of injection to much later on. So there's a very high temporal resolution, and unlike CT or MR, we can only image at a certain point in time. You can see, for example, if you're looking at a tumor, you can see its entire vascular pattern from the early arterial phase to the late phase. Ultrasound also has a high spatial resolution to look for septation and small nodules. Another advantage, of course, is there's no ionizing radiation. You can perform multiple injections as long as you stay within the 5 cc's limit. And typically, an injection for a liver will be 2.5 cc, so you can do at least 2 injections. And there is, again, a lower risk of major contrast reaction. There are, however, limitations, and basically they're the same limitations as of ultrasound. You need a good baseline examination. So if the lesion or an organ is not well seen by ultrasound, it is unlikely that administrating ultrasound contrast will improve visualization overall. Now, of course, it may improve resolution of particular lesion within the organ, but if you cannot see the area of interest to begin with, this is not going to be a helpful exam. The other thing is, does not provide global imaging, so you need to know what you're looking for so that you can focus on the region of interest. Having said that, in the liver, the contrast is around for several minutes, so you can, once you have evaluated your target lesion, you can look at the rest of the liver. It requires more radiologist involvement. Usually it's a 2-people procedure. There is a sonographer who scans, radiologists to inject. And it is only FDA approved for liver imaging. However, it can be used off-label, and many of us have used this off-label for other applications. The contraindications are specific allergy, which is uncommon. And there is an FDA black box warning, so you have to observe the patient 30 minutes after contrast administration, and you need to have a crash cart in the area, just like you would for CT or MR. The other consideration when you start this is, where you're going to schedule the patient. It should be in an in or outpatient setting, particularly knowing that there will be more radiologist involvement. There is a learning curve. And the other thing is reimbursement is now available, and these are the 2 CPT codes. So how do we do it? Well, the first thing you need to do is to have a good grayscale and potentially color Doppler ultrasound for baseline. You need the patient to have an IV, and this is, again, impact your workflow because most patients for ultrasound will not have an IV, so you need an IV. Ideally, you want at least a 20 gauge needle, and you need a 3-way stop attachment. And I'll show you why in a second. And what you do is you mix the contrast, and you agitate it for at least 40 seconds to resuspend the bubbles. You make sure the contrast mode is selected on the scanner, and you inject up to 2.4 cc's of the microbubble solution. And because that's a very small amount, you follow it by a 5 cc saline flush. And that's why you need a 3-way stop, so that you can immediately, following your bubble injection, do the flush. And you start real-time scanning and the timer on the ultrasound machine at the start of the bubble injection. So this is the contrast, the bubbles come in that kind of powder, and you need to resuspend. There's a very easy kit. You need to agitate it for 40 seconds, and you have this milky solution. And another little tip is that when you inject the contrast, you have to make sure that the contrast is injected in the line that goes straight to the patient, and the saline is injected at 90 degrees, because you don't want the bubbles to have to take this turn and be destroyed. It's important to do proper pre-contrast planning. So you want a good grayscale image, and you can see how, again, because of the low mechanical index in the contrast mode, the grayscale is a little bit degraded. You also want to position the patient in such a way that you can see the adjacent tissue, so that you can compare enhancement within the lesion to the adjacent tissue. You also want to keep in mind that the exam is going to last several minutes, so that you put the patient in a position where the patient is comfortable and you can see the lesion and the organ in and out when the patient is breathing. So in most cases, a longitudinal approach is better because you can see the lesion, you can see the organ, and you can see it as the patient is breathing. And we recommend that the patient has quiet breathing. So pre-contrast planning is important to optimize your examination. So what we do is do continuous recording for the first minute to have this high temporal resolution, and that way you make sure that you're not missing for an arterial phase, for example. And you do, after you've recorded the first minute, you do intermittent scanning with 10-second clips every minute afterwards, and you make sure that you lift the transference between, because the more you scan, the more bubbles you destroy. So this is basically an attempt to preserve the bubbles in circulation a little bit longer. For the liver, because you're looking for potential hepatocellular carcinoma and very delayed de-enhancement, you scan for 5 to 6 minutes, about 3 minutes for the kidneys, and you can do multiple injection up to 5 cc's. And it's really important to record the clips so you can review them at the time of interpretation, because oftentimes these go very quickly, and so it's important to sit down when you interpret and relook at your clips. So let's look at some liver applications. So we all know that the hemodynamics of the liver. So you have, with ultrasound contrast, you have a hepatic arterial phase that starts at about 10 to 20 seconds and lasts to about 35 to 40 seconds. You have a portal venous phase from 40 to 120 seconds. And then remember, we don't have an interstitial phase, so we call this the late phase of bubble clearance. And we know that the contrast bubbles stay in the liver vasculature for several minutes. So this is an example of just a normal liver. This is a patient who had a very fatty liver. We weren't sure whether this was a mass or not. And you can see here the contrast coming up in the artery. And then there's progressive enhancement of the liver in parenchyma in the portal venous phase, just like you would see with CT or MR. So when we look at liver lesions, we look at the pattern of enhancement. And so generally, benign masses, depending on what they are, will have a various pattern of an enhancement in the arterial phase. So for example, hemangioma will have this nodular peripheral enhancement. Focal nodular hyperplasia, where we have intense arterial enhancement with generally centrifugal filling. Adenoma are also hypervascular in the arterial phase, but they need to be more heterogeneous. But what is important is in the portal venous and delayed phase, benign lesions remain iso or hyperenhancing. In other words, there is no washout, perhaps with the exception of some inflammatory adenomas. By contrast, malignant lesions will have washout in the portal venous or delayed phase. So if we look at metastatic disease or lymphoma, usually they have an early washout by 30 to 40 seconds. And in the arterial phase, they can be hyper or hypoenhancing depending on the type of metastasis. But even because they're supplied by the hepatic artery, even hypodense or hypoenhancing metastasis, oftentimes you'll see an early rim of enhancement in the early arterial phase. By contrast, hepatocellular carcinoma will have oftentimes tend to have delayed washout. So they can wash out after 75 or even 80 seconds, or sometimes even later. That is why we scan the liver for at least 5 minutes. In the arterial phase, we all know that usually they are hypervascular or hyperenhancing, and sometimes you'll be able to see the irregular hyperenhancing disorganized vessels. And then cholangiocarcinoma have kind of a mixed pattern between metastatic disease and hepatocellular carcinoma. Oftentimes, just as a case I showed, they can have peripheral irregular or heterogeneous arterial enhancement, and then they tend to wash out earlier than hepatocellular carcinoma. But of course, many cholangiocarcinoma will be associated with biliary tree dilatation, so that's an helpful finding in the differential diagnosis. So again, look at the washout. So, for example, this study who looked at 147 hypervascular lesions, there was washout in 97% of malignant lesions, and the majority of, but not all, of course, the majority of benign lesions did not have washout. Only 36% had washout. So if you have no washout in the portovenous phase and the kind of delayed phase, usually that indicates a benign lesions, and the majority of them are either iso or hyperenhancing compared to the normal liver. By contrast, a lesion that washes out is really associated with malignancy. So this is an example of a hemangioma. You can see this echogenic mass in a good classic location by the dome of the liver. And here on the early phase, you can see this nodular enhancement right there. And then a more delayed phase at 2.5 minutes almost, you see there's more nodular enhancement. Now, some small hemangioma may fail completely, but many of them will not. And this patient had a CT scan several months later, and you can see again the classic appearance of hemangioma. There's another smaller hemangioma right there. This is a patient, a young 47-year-old woman who has this kind of subtle lesion in the liver here. And so I'm going to show you the arterial phase, so you look very carefully. You can see here that there's very rapid early enhancement within 20 seconds of this mass, which is enhancing very intensely and very homogeneously. And so when we look at the delayed phase at 2 minutes, it's still hyper-enhancing compared to the rest of the liver. So it's a good pattern for focal nodular hyperplasia. And the patient had an MR, again showing the hyper-enhancing lesion in the arterial phase here. And then iso becoming dense, iso-enhancing to the rest of the liver in the portal venous phase. So this is an example of a focal nodular hyperplasia. Now let's look for some malignant lesion. This is an unfortunate 29-year-old man who was feeling unwell and came to the emergency department. You can see he has extensive liver metastases, necrotic nodes, mediastinal, and pulmonary masses. So of course, in a young man, you think about a testicular tumor. So we looked at his testicle. He had a scrotal ultrasound that showed a lot of microlithasis and kind of strange appearing bilateral testicle, but no focal mass. But still, we're suspecting still germ cell tumor, perhaps from a burnt out germ cell tumor. Anyway, for diagnosis, he needed a biopsy, so we did a liver biopsy. And this is at the time of the liver biopsy, you can see this hypo-enhancing mass compared to the rest of the liver very early on. This is only 30 seconds here, but you can see again this rim of enhancement. So this is a classic pattern for metastatic disease, and this patient had metastatic choriocarcinoma. Another example, another relatively young patient with a pancreatic mass. So let's look at the liver here, and you can see here very quickly arterially enhancing masses in the liver. Okay, and then if we look at the more delayed area, you can see that by the beginning of the portal venous phase here, they're starting to de-enhance a little bit, and then more delayed, you can see that they are hypo-enhancing. So this is early enhancement, and the patient had a pancreatic mass. So look at the CT scan, you can see that the patient has a hyper-enhancing, hypervascular pancreatic mass with this vascular lesions in the liver, and this is metastatic neuroendocrine tumor. And we know that this metastatic metastases typically have early arterial enhancement. Now, you can use the late phase also to look for lesion detection, because as I said, the contrast will stay in the liver parenchyma for several minutes. So this is a patient who had a scan for pulmonary embolism, and at the bottom of the scan, you saw this kind of hypodense lesion in the liver on the CT. She has some liver lesions you can see on the grayscale ultrasound, but she came for biopsy, and so we gave her contrast, and you can see with contrast that there are many more lesions. They're typically hypodense to the liver. And so you can find perhaps a more favorable target to do a biopsy in a more superficial location or perhaps larger lesion. And this was a patient with metastatic breast cancer. So again, you can use the later phase after you've characterized the target lesion to look for additional lesion in the liver. Now, this is an example of a patient who had hepatitis B and this echogenic mass in the liver with a hypoechoic rim. So, of course, you worry about tumor, and because of his history, you worry about hepatocellular carcinoma. So he came to us for biopsy, and the time of biopsy, to be able to better see the lesion, we gave him contrast. So this is the arterial phase at 25 seconds. You can see here's the lesion on the grayscale. Here's the lesion here, which is hypervascular to the rest of the liver here. And then at 1 minute, it has not washed out yet. And then at 5 minutes, and we started seeing that at 4 minutes, but you can see that there is subtle washout right there. And so, we biopsied using that hypo enhancing area compared to the rest of the liver. That was where it was easier to see. And this turned out to be a moderately differentiated hepatocellular carcinoma. And this is what HCC typically do. They will have washout, but which is more delayed typically compared to metastatic disease. So there are liver-specific limitations. If the lesion is very deep, it's more than 10 centimeters, really, the contrast gets very attenuated. If there is marked hepatic steatosis, or if there is a small shrunken liver, which is way under the rib with limited ultrasound windows, then these patients will not be a good candidate for contrast. Now let's talk about the other big application, which is renal application. So this is an off-label use, so you have to consent the patient and use your institution policy for off-label use of products. But I basically tell the patient, we use it all the time for liver, it's the same, and I've never had a patient say no to me. Anyway, so let's look at the normal kidney. And I'll start this clip again. So you have the corticomedullary phase between 20 and 40 seconds. And then after 40 seconds, typically you have filling in of the medulla. So you have a nephrographic, more homogeneous phase. And remember, there is no excretory phase. And the kidney, typically the contrast will wash out after 3 minutes. And the other thing is that perhaps it's advantageous in the kidney to use a slightly smaller dose, maybe 1.5, 2 cc's. There is no good studies about it, but it seems like if you use more, the examination is almost too bright. And the advantage of using a smaller dose is you can also easily do multiple injections if you need to. So the best use of contrast in the kidney is really to determine whether a lesion such as this is a complex cyst or a solid mass. So see, this is a patient who had an elevated creatinine. She was also in the cardiac ICU. So I just went to the ICU, did this exam portably in a few minutes. So here's the after injection at 40 seconds. And then 1 minute, you can see that this lesion here, there is absolutely no enhancement. It remains black. So that means that this area is not enhancing. And this is basically a hemorrhagic cyst. And I think you can get your answer faster and perhaps better than a non-contrast MR, which tends to be indeterminate. Contrast it with this patient. So this is a 70-year-old man who had enlarging left renal mass. And so here's the MR, again, non-contrast, this kind of heterogeneous mass here. And then we give him contrast. So here's the lesion, and part of it is cystic. But if we look at this cystic lesion, you can see that there is an area here that is enhancing. So there is nodular enhancement as opposed to the last patient I showed you. And so we did the biopsy targeting this enhancing nodule, and this was a renal cell carcinoma, likely papillary was how the path came back. Again, you can see here the enhancing nodule. Now, solid, so it's very helpful really in the kidney for cystic masses. The solid renal masses, you can also assess them, you can characterize them, and they will have a different enhancement than the renal parenchyma on at least one phase because they don't have nephrons. So typically, just like you're familiar with CT and MR, clear cell renal cell carcinoma will be hyper-enhancing in arterial phase. If they are very large, they tend to be necrotic. By contrast, papillary renal cell carcinoma will have hypoenhancement compared to the rest of the kidney. But the challenges, of course, are lipid-poor AML of oncocytoma, which are also hypervascular and sometimes difficult to differentiate from clear cell renal cell carcinoma. So let's look at an example. This is again a patient who had a large, ugly-looking mass arising from the right kidney. Again, a patient with elevated creatinine. Here's the mass on grayscale ultrasound. And as soon as we contrast, you can see it's hypervascular compared to the rest of the renal parenchyma with a large area of necrosis. So the advantage here is also that you should target, if you're going to biopsy that, you should target the enhancing portion of the mass to get adequate tissue, and this was a clear cell carcinoma on pathology. This is a patient who also had a solid mass in the kidney. Now you can see here that this patient the mass is hypoenhancing compared to the rest of the kidney in the early arterial or corticomedullary phase, and it remains hypoenhancing to the rest of the kidney on more delayed in the nephrographic phase. And so this was at pathology a papillary renal cell carcinoma, and typically these are hypoenhancing compared to the rest of the kidney. You can also use contrast to look at perfusion. So this is a patient with renal transplant, and you are able to look at the perfusion. If there's a question whether there's arterial thrombosis or stenosis or even renal vein thrombosis, I think contrast is a very good way to increase your confidence level about what is going on. Now, there are other applications in preparation for biopsy or ablation. So it is helpful, contrast is helpful in improving visibility of small masses or allow you to target specifically the enhancing portion of a nephrotic mass to make sure you have viable tissue. It's also useful when you do ablation. You want to make sure there is lack of enhancement at the end of your procedure. It has been used also for looking at inflammatory bowel disease, to look for active disease. Also, and there's some more in clinical trials for tumor perfusion pre and post treatment, and also this is not something I'm going to discuss, but it's a very good VCUG technique in pediatrics, which is progressively replacing the the regular VCUG, because of course there is no radiation in this patient, which is a huge advantage in pediatrics. So this is a patient who had a small exophytic mass in the posterior aspect of the right kidney here, and you could see it but barely on the pre-contrast ultrasound. And you can see here, as soon as you start seeing, you see this subtle but definite enhancement. And again, this just shows you the beauty of this increased temporal resolution, because you can see the hypervascularity very early on, and this was a briefly hypervascular renal cell carcinoma. This is a patient that has a very large abdominal mass. You can see it's highly necrotic. So you want to make sure that when you're going to do your core biopsy, that you do it from the enhancing portion. And with contrast, it's very easy. You can again see enhancement in the periphery of the lesion, central necrosis. So we want to make sure that we target our cores in the enhancing portion of the mass. And this was a gastrointestinal stromal tumor. An example of inflammatory bowel disease, a 16-year-old patient with crohn and abdominal pain. So you can see there is thickening of the terminal ileum on CT, and then even on grayscale. And these patients tend to be very thin, and when the bowel wall is thickened, it's kind of relatively easy to see with ultrasound. You see the target sign here of the bowel. You can see that there's increased vascularity, but when you give contrast, here, your sagittal on this thickened loop of a terminal ileum, you can see very, very nicely that there is hyperenhancement of the bowel wall, and these dilated, stretched vessels, which are also increased, and this indicates that you have an active inflammation. This is active Crohn's. Finally, and this is still experimental, it's not really widely applied as in clinical practice, but you can do time intensity curve, placing a cursor within a tumor and comparing it with the with the rest of the liver parenchyma, and you can compare perfusion within the lesion and within the renal, the adjacent tissue, or you could also do time intensity curve pre and post chemotherapy, and there's studies going on regarding that as well. So in conclusion, then, contrast ultrasound is a powerful tool in selected cases, and I hope I've shown you some, application where you can use it. There are some obstacles that we still need to overcome. There's a limitation of the ultrasound that are inherent to ultrasound. Practice pattern, especially in the United States, where CT and MR is much more widespread. Issues of logistics, how are you going to schedule the patient, and issue cost and reimbursement, which is now finally being addressed. And I really thank you for having listened to this talk.